Fantastic. Okay, let's get going. So, hello and welcome, everybody. Good evening to those of you watching live, those of you watching the recording later or watching internationally. Thank you very much for joining us. Good to see you. So, my name is Matthew Bryon. I'm Managing Director of Thrum Leadership, and this is the first Thrum webinar. So, it's the first of its kind with many more to follow. And the purpose behind webinars is to share the insights from our research. So, Thrum is a research group made up of clinicians, coaches, educators, lawyers, mediators, all of which have a passion for creating change within the healthcare sector. And we're keen, as part of these webinars, to take some of the insights and research we've developed over the years, take them away from the journals and away from the corners of our website, no matter how proud we are of our new website, and sharing them more directly with you who are in the sector and working hands-on in the healthcare space. A bit of context. In the recent years, numerous studies and systematic reviews have identified positive correlations between leadership and improved patient care, staff satisfaction, and more importantly, overall organizational performance. As a result, never before have organizations invested more time, money, and resources into leadership development. Well, with this being said, the expectations and scrutiny are increased as well. Things like CQCs, ICDs, so integrated care boards and integrated care systems, are putting more oversight over how trusts and organizations perform, but also whether or not they were returning on investment, and also making sure that what we're doing with the money we have, the resources we have, are being used effectively. You would have seen recently in the news league tables that the rankings of certain trusts, both acute and non-acute, and then more generally, how different levels of the system interact, looking at performance. As a result, expectations are rising. There's expectations rising around innovation in regards to digital health and sustaining clinical excellence. There's a need to integrate across trusts, community organizations, charities, and private partners to ensure that patients get the best possible care across their local environment. There's a need for improving financial stewardship and team behaviors to do more with less. And in a general sense, aligning everyday processes that every team goes through with the values of the trusts and the organizations they work in, but also patient experience. So these challenges are repeated across the entire system. So to give a sense of the scale of the issue, or at least the challenge, we have 42 integrated care systems, which within them have 202 provider trusts. And so within those trusts, we have 1.37 million full-time equivalent NHS staff members. We also have, according to NHS statistics in June this year, 100,000 vacancies, so that's about 6.9% vacancy rate for full-time staff, which are either filled by temporary workers, bank workers, or are just missing in the system. So every organization is therefore under pressure to act. And how they're responding to it is 202 times or 42 times if you're looking at the ICS or the provider trusts. So trusts are using a mixture of internal and external providers. Budgets for leadership development aren't always ring-fenced or protected, and they vary by role or discipline. What doctors get in terms of leadership development in a trust in Oxfordshire will be different to what nurses get in a trust in Birmingham, and vice versa. There are national frameworks and providers, but there's no universal quality checks for clinician programs. I'm sure many of you on this call have either heard of or been on national programs or programs within their trusts. But when we're commissioning or when we're speaking with partners, there is no mandatory elements that must be included in every program, which is great for in terms of expression and to focus on what's really needed. But if you're looking to think about what good looks like, it's an issue. So everybody is in the same boat. We've got 1.37 million, all with the same challenge and the same good intentions, but no one is speaking the exact same language. The starting point for you as professionals in the sector, based on available evidence, is to understand what does good look like. Next slide, please, Oscar. So today's objective is quite simple. It's how do we identify and design an evidence-based leadership development program. So hopefully by the end of this workshop, you will have a kind of checklist in your mind, or at least a starter for 10, for what good looks like. So if you are a commissioner, facilitator, or a participant, and somebody is coming to you with a proposal idea for a program, or you are looking to start thinking about what could be a good proposal to push forward outcomes in your trust, organization, or even GP practice, community practice, etc. What would you be doing next?
This is a photo of me as a first-year junior doctor. I'm clearly going to go the other direction. Matt started big with the system. I'll start with me. This is me doing an impossible task, holding the pages of what was the entire surgical team in my small hospital. I spent the next hour after this particular photo just collecting jobs that urgently needed to be done, while my friends assisted in what were, fair enough, essential and acute surgeries. At this time, I was pretty clinically competent for what was expected of me at the time, but I was really out of my depth in terms of leadership and in terms of how to work effectively with others. I was pretty curious why that was. I'd been through 6 years of medical school in leading me to this. So my question really was, how do we better prepare medical students for the leadership and teamwork aspects of their roles? And in already quite cramped curriculums, what is really important to add to those to help make sure our doctors were ready? That curiosity, and to be fair, a very generous scholarship, took me to the UK for a DPhil in leadership development in healthcare based in Oxford. And I focused on what works in terms of leadership development. So my question, if we've got it, is I went to Oxford for my DPhil. That's kind of formed the basis of how we know. I want to know how you know what works in terms of leadership development. When a program has successfully had practical value for you, your team, or your organization, what about that program caused that impact for you? I'd love to just have a couple of ideas from each of you on this before we jump into my side of it. Let's go sideways. Please do continue to write that if you're not quite finished. You can write that even once it's gone off the screen, and we're going to come back to my side of the program. So how we know what we know, as well as conducting our own evaluations and research around our programs, we've completed a series of systematic reviews of the literature that other people have published as well. And those reviews have helped us give the definitive answers for the best practices in leadership development in healthcare. Those include a systematic review of leadership training for medical students, which is where I started. For doctors as our second one, evidence-based medical leadership development. Then we moved slightly sideways and did one for healthcare scientists as well. And noting similarities, moved on to do an umbrella review for leadership development across all facets of healthcare. Adding to that, so this is our systematic reviews, adding to that, in Oxford, I discovered quite quickly that there weren't too many doctors with academic backgrounds in leadership development. And I got asked to run first a program for doctors, which became rapidly and sensibly a program for health professions from all backgrounds, including management backgrounds. Then a program for healthcare researchers and Masters in Global Healthcare Leadership. Thrum came to be fundamentally out of a frustration from seeing a lack of persistence, lack of presence of good practices in leadership development broadly. We really wanted to role model application of the learning that we found in our work and in our systematic reviews. We've since run programs for students, for doctors, for nurses, for researchers, for managers in Oxford, nationally and internationally. So systematic reviews, running programs ourselves, evaluating programs, both ours and others, and publishing those evaluations. And as a bonus part, I've been an editor for BMJ Leader, focusing as the theme lead for leadership education. So we're going to present today mostly learning from that final umbrella review, but with little sprinkles of what we've learned from practice as well. So the systematic review that was led by Juliet Phillips and our team included a total of 86 published systematic reviews, which had more than 1,500 unique articles evaluating leadership development programs. It was mostly focused on doctors and nurses, as you can see here. So this is the proportion of the reviews that included doctors, nurses. The reason why that's more than 100% is because many of them included more than one profession background. So lots of different healthcare professionals with a particular focus around leadership development for doctors. What was present in those 86 systematic reviews and 1,659 unique articles. Let's go on to what the findings of those were. So we're going to start with methods. This is out of 86 reviews, and it's going to be a really messy slide that I'm going to try and ask you not to get too distracted with. So what you see here is on the top, the systematic reviews that showed particular methods worked, and a count at the right-hand side. So that count might be a useful thing to look at. On the left-hand side, you see different methods that we found support for in these systematic reviews. These are deliberately done in descending order, so you're welcome to get distracted by reading the ones down the left-hand column and seeing which ones were most popular. So the things that we found really worked were those up in the top. So these ones, at least 10 reviews supported experiential learning, which included action learning, quality and service improvement projects, self-improvement projects, role play and simulation, coaching or mentoring, multiple learning methods, that is combining lectures, seminars, performance appraisals, feedback, experiential learning and such, with a note that using didactic teaching alone was found to be less effective. And the use of reflective feedback tools and the use of a longitudinal design. So not just having a single workshop, one and done, but having a deliberate plan to have multiple touch points with participants, with students, so that they can learn over time. So as we're going from there, methods, we said methods, particularly those methods that are experiential, came out as being effective in those systematic reviews. If we look at content, so this will look quite familiar, and we're going to bring it up again. The first thing I'd like you to do is think about how this looks. It looks as a whole slide compared to the last one. So the first thing that jumps out to me in this is, fine, it's laid out the same way. These are the reviews that supported this particular finding, with the counts on the right-hand side and the findings on the left. And what jumps out to me is that this one on the right has 7 reviews out of 86 supported the most supported of the particular types of content, compared to 31 in methods. Not even one content area was supported by 1/10 of the reviews, which would have been 8 or 9 reviews. So where there was support for certain methods, there was much less support for any particular element of content. And so I'm going to hide off the ones that were supported not by too much. We see that there seems to be a bit of support for the development of interpersonal skills, which included building professional networks, communication, collaboration, teamwork, shared decision-making, recognizing team member competencies and inclusivity, and a bit of support also for personal development and self-awareness as a content for leadership development. That's particularly in areas like self-direction, reflection, and self-awareness. So some support for particular content, but not nearly as much as there is support for methods. So the number one point for this is that the methods for leadership development programs seem to be much more important than any specific content. And specifically, the more active methods seem to be associated with more change. For this, I would note that this is not to be taken as being a depressing finding. It is, in fact, probably a call to action that the content that we include in leadership development programs really should be tailored for the people that are in front of us, thinking what are their needs. In fact, in the methods slide, you might have seen on the left that needs assessment and tailoring of programs was one of the core outcomes, core design features that were associated with impact for participants. So active methods, and they're more important than any specific content. The second thing that came up for us, I'm going to use a graph from our systematic review for doctors. I'm going to first make it a little bit easier to read. So we're going to remove the ones that said not reported, and we're going to remove the lower reliability studies. So this is just the high reliability studies. And what we're looking at on the left-hand side is the proportion of those papers that reported organisational outcomes from a program, and whether the faculty were from external to a program, from external to an organisation, that is, from internal to the organisation itself, or whether it was co-delivered by a combination of people from inside and outside. And if you look at the proportions there, it's a pretty stark difference between the programs that were delivered entirely externally versus the programs that had a mix of faculty from inside and outside an organisation. I have a pretty clear theory here for why this happens. Why do you think this happens? As a moment for a pause, why do we see this? Knowing that you can't actually answer me right now, my answer to this, my theory for this, is that really leadership development is a practical and experiential skill that is situated within a context. And so to really support people really well in terms of their leadership development, we need a combination of leadership expertise, educational design expertise, and lived experience, what it's like actually leading, actually working within a particular organization. And while people coming from outside an organization will tend to have leadership and educational expertise, if you're from outside an organization, you cannot have lived experience, what it's like being a person inside that organization. If you're an internal staff member to start with, you have generally some lived experience as to what it's like being in that organization, and you might be able to develop or already have leadership and education expertise, which to me is why that one is higher up. And by mixing people who have those leadership and education expertise and people from inside an organization who have lived experience, that's the most obvious way that we can have a well-rounded faculty for a program. So we said, first of all, methods are more important than content. Second, co-delivery tends to be more impactful than just external delivery. And finally, active methods are more important than passive methods. So this is a snippet of the research. We're going to think about, well, what does that actually mean in practice? And Matt's going to give you a little bit of an example of how we have applied that in practice.
Fantastic. Thanks, Oscar. So yes, so thinking more broadly about some of those larger design elements that go towards what creates, or what is suggested to create impact, we just dive into a little bit more of a case study. So since 2017, we've been running a program called the Emerging Leaders Program with Oxford University Hospitals FT. So like many trust initiatives, it's grown over time. But since starting 2017, we've just concluded cohort 11 this year with an average of 30 participants per year. So that's down just over 200 or so alumni of our course. Each cohort of the 11 gets a 6-month program made up of 6 workshops alongside leadership projects where they can test out some of their learnings in practice. And it concludes with a reflective assignment. You will recognize, for the eagle-eyed viewers, many of the program elements Oscar highlighted at the end of the review being reflected also in the design principles of the program. I want to dive into a couple of them. I won't cover all of them today. One is around mixed faculty and contextualized learning. And so to root the learning in real organizational life, we actually, as part of our initial engagement with the trust to make sure that what we were doing was actually meaningful and useful for them, we made connections and had dialogues with lots of different trust members across the organization, from junior to senior. And so that resulted in many of them wishing to share their knowledge and also to give some grounding for the participants on the course. So again, part of the mixed faculty approach, we as fund would provide some of the leadership insights, that they could actually provide more of the internal contextual evidence. So what does this look like in practice? In practice, they delivered workshops on content areas like financial stewardship, business cases, innovation, digital health, and policy improvements, all session areas where it had a real advantage to have that internal knowledge of how things worked, what levers were that could be pulled, and what was actually the barriers that could stop certain change and innovation occurring. At the same time, we were also able to supplement that with things like things around conflict, things around leadership theory, and working within teams. So it created a really nice holistic pairing of the mixed faculty. Alongside that, we also invited the senior stakeholders to come and join something called a fireside chat with a senior leader. And the purpose of these fireside chats is basically a mini discussion or interview with a senior leader from the trust, with the idea being it humanizes leadership. So instead of having the board of trustees or your COO or your chief medical officer or your chief nurse as somebody who's slightly with notes and removed from your day-to-day work, actually having the opportunity for half an hour to hear from them, to understand why they work like they do, how they work like they do, and where they got to where they are. And actually, as you can imagine, we find out that often the pathways they got to where they are incredibly complex, but also very simple. So really, it's the more you know about your senior leaders, the sense of separation is reduced. Next slide, please, Oscar. I'll come back to some of these other elements. So alongside having mixed faculty, I also wanted to speak a little bit about multidisciplinary participation. So as Oscar mentioned, the first cohort started with 13 doctors, but the program now welcomes a wide mix of participants across these sites. So that includes physiotherapists, pharmacists, OTs, nurses, managers, administrators, ward housekeepers, researchers, and others. Now, as Oscar mentioned, this really reflects what the everyday work life of a professional in the NHS is. While there has traditionally been siloed training offerings for doctors or nurses, and that's normally been the kind of historical case, there's a real value that I'll talk a little bit about the impact of actually having all these disciplinary groups together. Even if you're not working with that person in your team on a day-to-day basis, just having an understanding of what their priorities are, why they're there, and what impact they're looking to make can really make a difference. Next slide, please, Oscar. So alongside role, we're also talking about job seniority. So as you can see, over time, it's become more and more diverse in terms of having junior, middle, and senior roles. The kind of descriptor for these is split across bands. But basically, it's people who are developing into line management, managerial roles, and people who are in more governance or senior positions. So it's a real need to have that reflected in your programs, because again, otherwise you continue to have that separation between junior and senior staff, and you continue to lack that ability to just make that connection and to reach across the aisle and just say, hi, I'd like to speak to you about this, whether that's an issue, an innovation, or just something you think can be done better. Next slide, please, Oscar. So we'll talk a little bit about mixed faculty and multidisciplinary groups. I'd also quite like to speak about a quite key element, which is experiential learning. So as Oscar mentioned, the methods are more important than the content. Not the content is important, but just to say that the methods are key. And so as part of that, it's really vital for each participant in a program like this, especially if they're doing it over 6 months, has an opportunity to go out into their daily work and actually try some of these ideas out. So in the Emerging Leaders program, we do something called action learning groups or action learning sets, where students in groups have opportunities to share problems or issues they're facing on a day-to-day basis. And the group, in a non-judgmental and non-critical environment, actually helps that individual to work through their problems using open questions and other tools of support. Now, the baseline idea behind this is that inside every participant, the answer is there anyway. It's just that they need to unpick the ideas, unpick what's causing these barriers, and pick what may be leading for them or others to create that issue, and how, as a group, they can work together to respond to it. Now, having that consistent but supportive set of peers within the work environment coming back lunch after lunch is really important, because it holds you to account, but it also continues to give you more insight and more evidence as you go on. For example, this happens, what should I do now? And kind of building on those problem sets and making sure that whatever happens, you're not left in the lurch after one workshop. I'm going to pass back to Oscar to summarize a little bit what we've learned so far.
So this is just coming back to the full summary of what works in terms of leadership development. Hopefully from Matt's part, you've seen a little bit of how we've applied this in practice. That is, methods are more important than content, and particularly we need to have active methods rather than passive methods. Experiential learning, coaching and mentoring, multiple learning methods, reflective feedback tools, longitudinal design, multidisciplinary cohort, team or group work, mixed faculty, needs assessment, and or tailored, small class sizes, face-to-face, goal setting, creative tasks as well. So that's the whole lot all there. And in addition to that, co-delivery is better than external delivery. The final thing that is often missing is around embedded evaluation, which is a little bit of a nudge towards our next planned webinar. But Matt's going to talk us through next steps here.
Fantastic, thank you. So yes, in terms of next steps, we will share the webinar recording today. We'll also share, Oscar mentioned, a multiple number of both research papers, but also just more informal papers we've been working with our trusts, and so it'd be good to give you the kind of backside knowledge for that. I will also share more detail in a one-pager on our design principles, so some of the elements we've been covering today. And for those of you who wish to continue the discussion, it would be great for those who are interested to have a chat to explore further how you may be wishing to design or deliver a program within your own trust. We are running programs in multiple trusts throughout the UK, so it'd be useful if you would like to come and join or attend or shadow a program that we're already running. I appreciate it's always useful when you actually see it firsthand to see, one, how it works, but also to see the impact the students are having, and also to get some of their insight too. And more broadly, as Oscar mentioned, we are a research company, primarily looking at how best to create impacts through both programs we deliver ourselves and evaluate ourselves, but also the ones that are already happening and the best practice out there, and making sure that that's shared with other people. So if you're already working on an exciting, impactful program, you're either mid-evaluation or just haven't started yet, that you're looking to make an impact in your trust or your organization, get in touch, because we'd love to hear about it, see what new ideas are being used. As Oscar has highlighted during this, the only reason we know about all of this really insightful and vital information across both the UK but internationally is like pulling all of these pieces of information together. So most GPs or consultants or chief of heads of trust within their own organizations aren't going to have that at their fingertips unless we do some of the work to kind of consolidate and summarize for you. So please do be in touch if you're interested or excited about what you're doing. So today is very much been focused on design principles. We were originally going to try and do both today, but actually we realized we could quite do about 2 weeks worth of content on both of these areas. So it's really important for us to actually break it down a little bit into design, evaluate, and delivery, so we can actually give you all the information you need. So today's been more about what should be included in the program for it to have impact. And next time we're going to think a bit more about how do you actually evaluate, how do you create a framework or a skeleton to that program that means that you can actually see and capture impacts on the back end. The main ability we have for evaluation is to actually predict and then measure outputs. And if you don't do that, you're unable to kind of make changes and make decisions and move forward. So that's very much it from us for today. Thank you very much for joining. As mentioned, we'll share the recording with you forthwith. And please do get in contact. So that's our next slide. So as ever, we've got multiple years worth of research and insights, blogs, more informally for you and your team, things that are less academic, but just more tidbits of leadership development that we run on our programs on our website. Please do have a look. If you want to have a chat or want to share any feedback or have any insights following the call today, please do get in touch as well. We won't make you jump on a call. We can just have an email exchange or DM if you prefer that way too. It's all very much about just sharing insights we're going through and also making sure that everybody has the access to the most recent and reliable evidence. So that's hopefully what we've done partially today. So thank you very much for joining, and we'll be in touch with you forthwith about future events and programs.